Yes.
Dr. Ismail, you said before the lunch break, in answer to a question, that you didn't tell patients in the 80s that the concentrates they were using might cause liver disease, although you did explain liver function test results to them. Do you think you should have told patients of the risk of liver disease so that they could decide for themselves if it was a risk they were happy to run?
I know that this is a question you're reading, but if you remember what I said previously, I said when patients were told about the risks, they were told with the first consultation when the option of treatment were offered. What I said in my before lunch, I said I would discuss with the patient the result of the liver function test, and if they are abnormal, tell them that they are abnormal. And if they ask me what they mean, I said I would not know, but I would refer to the hepatologist. So I did not deliberately not tell a patient that they've got an abnormal liver function test and whether they want to stop the treatment they have or not.
Could I just ask, sorry to interrupt. I just wonder if I can stop you there. The reason for that is the running transcript, which I have, indicates there is no sound. So just if you wait, bear with me, Doctor. I don't know if that's something which is wrong with my communication here, but it looks as though the transcriber isn't hearing what is being said in the room. Could we just check this? Sorry for interrupting, Doctor. The reason for doing it is this, that not only are your words being heard and online, if they can be heard, but they're also being transcribed. I'm being told there is no sound. If that's right, then people can't hear what you have to say, and that's obviously the whole point of this. And also, it can't be transcribed. So for both reasons, we'll just take a break and see what's happening and see if there's... we've got it back.
Yes, I understand.
Good.
The position
We're
is now
back.
resolved.
Good. Position is resolved. Thank you very much. Do you want to ask that question again? I'm sorry to have to ask you to go through that again.
Yes. What I'm trying to explore with you, Doctor, is the extent to which you advised patients of the risks involved in the use of concentrates, specifically the risk that concentrates might cause liver disease.
Okay, what I'll do, I'll start right from the beginning because I'm not really sure whether you heard me, Ms. Richards, or not.
Assume we didn't hear anything, please, and
okay.
start again.
What I said before, the risk of the treatment the patient likely or could have would have been explained with the first consultation when the treatment was explained. And I certainly did that when I had a new patient. I certainly did that when a patient who have not had treatment before needed to have concentrate. But what I did is, as I explained before lunch, when a patient would come to see me, we would go through, after examining the patient, we would go through the results of the patient. And if the results, I'll say that your blood count is okay. Oh, by the way, we did a liver test and that showed an increased enzymes. And if they ask me, what does that mean? That is probably related to the treatment you had. What does that mean, doctor? I really do not know what's going to come out of it. But if you like, I could send you to the liver doctor. Would he have any treatment to offer me? Not at the moment. We do not have any treatment because we do not know the cause of it. But I would not have held any information from the patient. I have not had any patient who would turn to me and say, by the way, if you think that is causing the disturbance in my liver test, I'd rather stop it. I've never had that. And I have never had a patient who would say, would there be a possibility to switching to another treatment and seeing what happens? I've never had that.
So is this right, Doctor, that because in the period in the early to and mid 1980s, you were not seeing new patients, you were not seeing patients being treated for the first time,
Yes.
Your assumption is that they would have, any conversation about the risks of treatment would have taken place beforehand, whether with Dr. Kershid, Professor Bloom, or someone else?
Yes, I think, sort of when you see a patient for the first time, it is the usual practice to explain to the patient what you've got to offer to them. And it is usual to explain what is the known side effect of what you've offered to them. And you try to explain that to the best you can.
Did you ever, in the course of the 1980s, before the test for hepatitis C was available, diagnose non-A, non-B hepatitis in your patients?
Oh yes, I mean some of the patients who were referred from other centers were referred, and they already, with the first consultation, they said that we know we've got this condition called non-A, non-B hepatitis. The patients who I have, and they have this disturbed liver function test, and say, what does that mean? Well, we've got a name for it. They call it non-A, non-B hepatitis. But what does that mean, doctor? Well, to be honest with you, I don't know. Is it a virus? Is it I don't know. Until we know the answer to it, I don't know what the answer to that.
And was it your practice to record discussions about risks or discussions about non-A, non-B hepatitis in the patient's medical records?
If I am to see the patient for the first time, I certainly do that. And I'm saying that because that is my practice with patients, whether they are hemophiliac. As I said, the vast majority of my patients were patients with the blood cancers. And I would document, maybe in bullet points, what is being discussed with the patient. It is usual that usually happens with the first consultation or when something new crop up. For example, if you want to offer a treatment and whatever, you would probably go back and talk about the reason why you're offering treatment and so on and so forth. And that usually would be either in the notes, in the letter, or both. That would be the usual thing. If you ask me, have you done it with every single case? I wouldn't be able to answer yes or no unless I see the notes.
Can I then move on to the question of AIDS? You've said in your statement that you're not sure exactly when you came to know about the association between blood and blood products and AIDS, but you've recorded in your statement that the Centre for Disease Control in Atlanta published its first report about AIDS in haemophiliacs soon after you started your post as a consultant haematologist in Swansea in 1982. And indeed, we know that publication was July 1982. Does that mean... Sorry, carry on.
Sorry.
Does that mean that at some point, soon after you started your post, you became aware of the CDC announcement?
I wish I know when, because I honestly cannot tell you when I knew. But at some stage, I knew about the CDC announcement about their report, and I knew, for example, I think it was in 1983, I've heard about the patient with AIDS in Cardiff. So I came to know about the CDC report at some stage, but with all honesty, I cannot tell you exactly when, which year.
You've told us in your statement, and you said earlier today, that in terms of the publications you read, they included the New England Journal of Medicine. I won't go to the detail of all the various articles, but does it follow it's likely that you would have read, for example, the articles and communications in the January 1983 edition in which there were various reports and discussions about AIDS?
I probably would have if you particularly show me what you have in mind, and I will be able to tell you whether that's something I know, it's something new to me.
We'll look at just one. There are a number of examples, but we'll just look at one. It's PRSE 302410, please. This is January the 13th, 1983, in the New England Journal of Medicine, AIDS and Preventive Treatment in Haemophilia.
This is Jane before this is...
That's right.
Yeah.
Do you think you would have seen that at the time?
I've seen it, but I tell you, it did not impress me then. Now, looking at it retrospectively now, it was a very far-thinking article, but it did not impress me at the time. And if you permit me, I'll tell you why.
Yes.
Because I think you probably know that the New England Journal of Medicine had a habit of the main editorial usually discussed the couple of publications which are important in that journal. Now, the two publications which came with this article, I think one is Lederman and one is Mitnov or whatever. Both publications, what they talk about a change in the lymphocyte subsets in patients with hemophilia who had constraints, okay? But if you look at what their result shows, in fact, neither of group of patients had any evidence of AIDS, and even the T4 lymphocytes were not below normal, but was lower than the patient who did not have the constraints. And if you go back to the last paragraph of this article, please.
Second page, please, Shumik.
And
if you zoom in the left-hand column, bottom of the page.
If you can, okay. So if you can take enlarge the last paragraph, and let's read this paragraph together. The fact that the hemophiliac at risk for AIDS is becoming clear. If the use of cryoprecipitate will minimize this risk, the current home infusion program need to be revised. The study report in this issue demonstrates in vitro abnormality of immunoregulation, but the numbers are too small for a definite comparison of the risk of different mode of treatment.
Definitive, I think.
Definitive. Unfortunately, the data are consistent with a greater potential, whatever. Physicians involved in the care of hemophiliacs must now elicit the risk. Preventing the complication or present may have to take precedence. If you go to the paragraph before that, it is the one before it, before the last paragraph.
The top of the page,
Yeah.
I think.
No, that's the one. I think.
This issue of the journal contains, I think, is what
No,
you're looking for.
ease of in obtaining commercially. Right. It would be difficult to design a home infusion program with a cryoprecipitate therapy, since the material must be stored in frozen state. The present program has been extremely successful and would be given by physician and patient only with a great reluctance. Yet, it is time to consider doing so, even though we may not have enough evidence to demand such a radical change. So that was suggested with this wording when there was no credible alternative. And the author clearly said, sort of cryoprecipitate is going to be a difficult thing to do, when there was no credible alternative to concentrate. The other thing is, of course, if, let's say, theoretically, or that we would do that, changing to cryoprecipitate, that means the BPL would have to stop providing us with NHS concentrate, and the logistics of the process of changing to cryoprecipitate is immense. And I already hinted to the difficulty of giving cryoprecipitate as home treatment, and I referred to the patient who described to me that cryoprecipitate dominated her life. And in fact, at the end of the day, cryoprecipitate unfortunately did not deliver the good. So that is the reason why, sort of most of us were not impressed by the suggestions. Now, 40 years later, of course, her prediction and other people's prediction proved to be correct. But at the same time, the World Federation of Haemophilia, the Haemophilia Society, the what is called the equivalent of the Haemophilia Society in the US, they all came to the same conclusion, that you could not stop using concentrates. And then you talk to people, sort of in big treatment centers, Cardiff, Manchester, Royal Free, and you mentioned to them, sort of, would we be going back to cryoprecipitate? Oh, you must be joking. It's impossible. So that is the reason why, cryoprecipitate was not a credible alternative. If there was a credible alternative, I think many people would have thought again, and continuing with the program. But there was no credible alternative.
Can we just look at this article again, the last paragraph? There are two parts to this paragraph. You've alighted upon the second part of it, which is the suggestion that there may need to be revisiting the current home infusion programme and the greater use of cryoprecipitate. But the first part of it is the statement that the fact that haemophiliacs are at risk for AIDS is becoming clear. Did you take issue in January 1983 or whenever you became aware of it in 1983 with that statement? Or did you understand by early 1983 that there was reason to consider that the haemophiliacs were at risk of AIDS?
But in the early 1983, and I think I've sent you so many references, and fortunately you've already had them because you send me back the reference numbers. There were two arguments going on at the same time. One argument is saying, look, the issues of aid in haemophilia is not related to an infective agent. It's related to the exposure to the antigen, that is the foreign protein which come with the factor VIII from another person. And there is a group which said, look, this is going to be very much like hepatitis B. And, stuff you really do not know, you did not know then as what is the credible. By 1983, 84, the argument that an infective agent is more likely became more and more acceptable until the agent was identified as the retrovirus HTLV3 initially. So there were two arguments going on at the same time. But I think I sense what you want to ask me. Did you share that with your patient, Saad al-Ismail? Well, you may know that the haemophiliacs, unlike other group of chronic illnesses, they were truly informed as to what is happening around them in the world. And I have yet to have had a patient who would come to me and say, well, I've heard about this. I want to stop using anything which may, sort of give me an infection. I would have happily discussed that with them and thought, what are the alternatives? The alternatives cryoprecipitate. But for the patient who were receiving cryoprecipitate, most of them have to end it having it in hospital, and for those who have to have it at home, it was a big issue. And I think one of the witnesses, which you sent me the statement for, said that he spent most of his life in hospital. I have not watched the program World in Action, but I saw it since when you actually included it in one of your evidences. And I managed to listen to it on the YouTube. And I remember one thing which Professor Bloom said to me, which I didn't understand at the time. He said to me, the hemophiliacs are aware that they are taking risks. And I thought he was referring to the hepatitis B. And I did not understand what he meant really until I watched that program, and I've got the references for the transcript which you've kindly sent, which I've read after watching the program, where Mr. Robinson, I think, said that we knew of the risk, and Mrs. Robinson said, I'm not quoting her exactly, but she said, we did not take a chance or something with our children's lives, but we knew of the risk. And I think the program was about hemophil. And she said, hemophil was a calculated risk. The reason why I went into such a long answer is to say that I really do believe that hemophiliacs knew the risk. And my understanding that with every single constraint, there was, sort of the drug information leaflet. And I was assured, I haven't seen one, but I was assured by Professor Bloom that in each one of them, a reference was made, for example, to the hepatitis, not to the AIDS. So I think, sort of a long answer to your question. Did I take action on the first sentence? No, because there was a counter argument and there was no credible reference. Did I discuss it with the patient? Well, none of the patients certainly raised the issue with me. And if I am to raise the issue, I should really have a clear view as which argument is going to be the more credible argument. I think the argument of an infective agent would have been acted on if there was a credible alternative to cryoprecipitate much earlier.
So as I understand the answer to the question that you correctly anticipated I was going to ask you, you didn't yourself tell patients in 1983, 1984 of the risk of AIDS. As I understand your answer, that's for potentially two reasons. Firstly, you're saying that in early 1983 at least, I think you're saying that there was a credible alternative explanation. And secondly, you're saying you assumed that patients would have the information themselves. Is that right?
That's right. And the third one is that there wasn't a credible alternative.
Well,
for treatment.
What's the basis for your assumption that patients in 1983 and 1984 understood the risk of AIDS from the use of blood products?
Well, I didn't understand fully the risk of AIDS from use of blood and blood products, simply because there were too many arguments, one pointing in one direction and one pointing in the other. And you asked me whether I've read the Lancet, and I said I read the Lancet in the library. And there were so many articles, leading articles in the Lancet, to say, look, this aid issue is this reduced immunity in the hemophiliac is very much related to the constrate, to the antigens in the constrate. And then there were other arguments saying, look, the aid in the hemophiliac is going to be different from the aid in the homosexuals and the drug abusers because there are certain mitigating issues in that population using nitrates and whatever, and that in the hemophiliacs, the processes may have altered that. There were so many arguments going at the time that it was very difficult to give an informed opinion to any patient as what I knew as for a fact then. When the virus was diagnosed and we had a test, it was much easier then to talk about it, but it was too late. In fact, it was too late by the 1982-83, as we learned later. But it was really to discuss something with a patient. You have to be informed. We may be able to talk about variant CJD later on, but when I call patients, I give them the opportunity to sit down and talk about variant CJD. Some of them said, why did you tell us this if you do not know the answer to it? And I explained, look, one of the reasons why I'm telling you is because of the public health issues, whatever. The point is you really only be able to discuss with a patient an issue if you really have made a firm opinion as what you want to advise the patient.
Dr. Ismail, if you didn't fully understand the risk of AIDS, what's the basis for your assumption that your patients were sufficiently well informed?
Well, the patients were informed because of the meeting of the Haemophilia societies. The fact that Professor Bloom called the patients, even from Swansea and their relatives, to go to a meeting in Cardiff. I think he probably had more than one meeting. The newsletters which the Haemophilia Society distributed, there were so many things distributed. I'm not saying that they were better informed than me. What I'm saying, for me to actually preach to a patient something, I really need to understand fully what are the evidences for it. Is it truly an infective agent? If it is an infective agent, like so many people have said, is it going to be like the hepatitis B virus, or is it going to be like the non-A, non-B hepatitis? There were so many issues I did not know. And that is not just me. I think the vast majority of people, unless they are strongly in one camp or another, are the same view. Some of the hemophiliac doctors told their patients, look, it is definitely not an infective agent. The others told them it is. But I did not really know which argument was going to be the true argument or the true cause of AIDS.
Did you ask Professor Bloom for his advice as to what patients should be told about the risk of AIDS?
I think we have talked about it. Professor Bloom had initially, prior to, I think, the first death he had, if I remember right, was in August '83. Prior to that, he thought that the AIDS is not going to be a big issue in the hemophiliacs. even in 1984, as you well know, he ran his survey of more than 100 haemophilia centers in including UK and Europe. He had 13,000 hemophiliacs who were treated, and that is 1984. Only 11 of them showed the acquired immune deficiency. Now we know things that we did not know then. Now we know that the incubation period of acquired immune deficiency of HIV is a long one. Now we know that it is, when the antibody test came in, we did not know what that antibody test meant until we had a chance to actually look for the transcript of the virus. So that antibody was not a protective antibody. There were so many issues that nobody knew, but you've asked me, did I speak to Professor Bloom? I spoke to him about this many times. And his views initially that we are not going to have to see, we are not going to see the same problem as in the homosexual population and the drug addict. We're going to see it in some of the patients, and he based his opinion on the survey that so many patients were treated, so many patients had HIV antibodies, but so a few of them developed. And then, unfortunately for all of us, when the disease started to progress, it was like a bushfire, really. Everybody was so depressed when that happened.
Can I ask you to look at...
Well, just before we leave this, can I just ask you a couple of things that arise out of the questions you've been asked, Doctor, if I may?
Please.
She asked, as I understand it, your first reason for not telling patients about AIDS was there were two different arguments. There was a counter-argument to the argument that it was a virus contained in the factor concentrate. Have I understood that correctly?
You understood that correctly, but if a patient have asked me, what I've heard about this, doctor, what do you think? I would have presented both argument to them.
Now, you were taken to the very first sentence in that last paragraph. The fact that haemophiliacs are at risk for AIDS is becoming clear. That's linked to concentrates. There's nothing in that sentence that talks about a virus, is there?
No.
And if it wasn't a virus, it was the factor concentrate, was it, that was creating the lack of immune reaction or the antigenic reaction which gave rise to AIDS, was it?
That's true.
So whether it was the argument or the counter-argument as to what was the cause, there was, on both accounts, a risk of catching AIDS from having concentrate. Quite how you got it was unsure, but there was a risk.
Yes.
So, in the light of that, was it really an argument to say that you shouldn't say anything about the risks of using concentrate to your patients, when both the argument and the counter-argument ended up at the same place, that it was the concentrate that was likely or could give rise to AIDS?
With all respect, sir, I did not say that it's not right to mention anything. What I was asked, would you have to explain the risk of AIDS to your patients? If I knew exactly what the risk of AIDS in a particular patient, I would have. But I did not know what would be the risk of AIDS in a particular patient.
That was all that I was asking. I just wanted to clarify that. Thank you very much.
It's a pleasure.
Could we have PRSE 302647, please? Doctor, these are the notes of a meeting at which there was a discussion on AIDS chaired by Professor Bloom. It's not a meeting you attended. It's the 24th of January 1983, and it was a meeting between a number of clinicians and representatives of Immuno at a London airport hotel. If we could go to page 3, please. You'll see there's a heading, Acquired Immunodeficiency Syndrome, bottom half of the page, please, Shumik. And there's a description given, what's said to be a summary of the current position from Dr. Krask towards the, if we go down so we can see the bottom paragraph in full, please. Thanks. So we can see in the penultimate paragraph it says some 800 people have been reported as suffering from AIDS and there was a 45% mortality. And then there's an update about the position in relation to haemophiliacs, and then a reference to other cases involving blood and blood product transmission, including platelets transfused in 3 cases, and specific reference to the case of a 20-month-old child who'd received several units, including platelets, and had developed a possible AIDS state. And we've referred to that elsewhere, Doctor, as the San Francisco baby case. We go over the page, please. And we look at the top half of the page. We can see there's express reference to the length of the incubation period, appears to be 6 months to 2 years, reference to only 1 or 2 cases having been reported, reference to possible precautions. There's then a discussion about articles in the New England Journal of Medicine and a distinction between concentrates and cryoprecipitate, and then comments on the possible nature of the transmissible agents, indicating that there may not be just one agent, but a mixture, i.e. possibly a barrage of viruses. 2 questions for you, Doctor, arising out of this. We know from this, we in fact know from other material as well, that Professor Bloom was aware of the case of the San Francisco baby case, the child transfused with platelets developing an AIDS state. Do you recall any discussions between you and Professor Bloom about that case and its significance?
No, but I recall what he has written in his report, that his litigation report. And I recall very clearly that he said in his report, I think he was in a meeting with the Haemophilia Society in 1983, only 2 months after his first patient died with AIDS. And in that report, he said, what was his wording? I became more circumspect about the possibility of, I've written it here somewhere. He said he was more circumspect than previously. That is in October 1983. Than previously with regard to blood products and AIDS. So really by then he clearly started to believe in the theory that an agent is probably responsible for the AIDS. So I'm very aware of that report, but as I said, until the virus was identified, many of us really, as the argument shifted more and more toward an infective agent, but it was only when the virus identified that it was convincing. And by the way, even when the virus was identified, so many papers appeared afterward saying that this is not the cause of AIDS. This is an opportunistic infection in patients who has got AIDS. So you could see how the arguments, sort of moved over the years. But if you ask me, what was the date of this meeting?
24th of January 1983.
Yeah. So if you ask me, has he shifted his opinion? Yes. Have he conveyed that to me? I don't know when, but I certainly read it when he shared the report with me.
Did he, I think the answer to this is no from your earlier answer, did he, whether following this meeting or otherwise, discuss with you the significance of the infection of the baby in California?
No, he did not.
Would you agree, and picking up on the chair's question a few moments ago, looking at this discussion, there are obviously matters which are not yet known, but there's no suggestion here that there's anything other than concentrates and a transmissible agent that are being put forward as the likely causal connection.
Yeah, but this is, as I said, one argument. There were a plethora of publications talking about an alternative arguments. And the difficulty for people who really was, I think even people in the haemophilia world, people in the oil-free and the like, initially they did not believe an infective agent was responsible until later on. So I don't think Professor Bloom was alone in that thought, really. I think, so if you're talking about people like him, he probably would have intermingled with people in the USA, in Europe, and whatever, and he was on regular correspondences with them. He reminded me so many times that, look, in Germany, they use more American concentrate than we use here, but they haven't had a case of AIDS. So all these things were happening. And he was a person who, as I said, was listening to all these views. And I said before, he wasn't an opinionated man. He was quite happy to shift his opinion when the argument pointed him in one direction or another.
What steps were taken at Swansea in response to the possibility that concentrates might cause AIDS in haemophiliacs?
Well, I don't know of any specific. What happened is that we became more adamant that mild haemophiliacs should not receive any, anything but cryoprecipitate or GDA-BP. We became more adamant that if it is all possible, children should be treated with a cryoprecipitate. Fortunately for me, as I said before, I did not have any new patients until the advent of the safe products came through. So in terms of the current patients we had, the only thing we could do is really monitor them and look after them. But in terms of changing the practice of treatment, there were no change of practice. Simply, and we use as much NHS concentrate, I've already said that before, as we could get hold of. And when the heat-treated product became available, we used that. But there was no other alternative, credible alternative in the severe haemophiliacs and for home treatment. So the short answer to your question, was there any specific measures apart from monitoring the patient more carefully? No. Apart from trying to answer any question which the patient, their mother, or their family phrase, no. But we answered the questions according to what we have read in the literature.
Could we have, please, HCDO 40-517_001? This is a letter dated the 22nd of March 1983. It was sent to centre directors from Dr. Krask, Dr. Ritzer and Professor Bloom. And you'll see it asked for the reporting of possible cases of AIDS, and various papers are there referred to. Do you know, this would have been addressed to Dr. Kershid as centre director rather than you. Did you see this as far as you can recall at the time, or are you unable to say?
I say that Dr. Kershid always would have told me what he received and what he's acted, and I think I found later on that he had some forms and he reported to the UK CDO, Dr. Krasko, whatever they've asked him to report. So I'm sure that Dr. Kershid would have told me that you've got another set of forms which you have to fill, and about the patients. But again, I do apologize for taking so long, because I could not remember in full, but that I'm sure he would have discussed it, knowing what used to happen. Whenever he received anything, he always mentioned it to me.
And if we could have HCDO 40517_002, please. This is a report, Dr. Al-Ismail, from Miss Dr. Krask, dated the 1st of March 1983. I'm not going to go through it in great detail. The inquiries looked at it on a number of occasions, or earlier versions of it. If we just go very briefly to page 3. You'll see the bottom half of the page says etiology and says several theories have been advanced.
Can I ask you
yes.
to etiology, the effect of a drug such as amyl nitrate taken by homosexual? This is not a factor of the disease, as have been described in patients who do not use the drug. Okay, so there were so many things which were going around the immunosuppressive cytomegalovirus. Sorry, and carry on.
Well, we can see that my main question about this document, Dr. Al-Ismail, is, do you think you would have seen this at the time? Is this one of the category of documents Dr. Kershid would have shared with you?
I can't remember seeing the document, but I think, knowing how we work together, is that he would have talked to me about it or mentioned it to me. But I cannot remember seeing the document myself.
Did you yourself report any suspected AIDS cases to Dr. Kershid or Professor Bloom in the course of 1983 or 1984?
No. I didn't see it.
You've referred to the Cardiff patient. What, if anything, can you recall Professor Bloom telling you, not about the individual patient or who they were, but about the fact that he had a patient under his care who had AIDS, a haemophiliac patient?
I don't know where I've heard it, but most probably because, doctors in Cardiff and Swansea talked on a regular basis. I don't know whether he told us or somebody else told us. I don't know. But I do remember that, sort of, if you like, the first hint that it is happening at our doorstep happened in 1983, but we didn't really know what is going to happen after. Is it going to be the odd case for whatever reason? We didn't know. We really didn't know. But I've heard about it, whether it was from Professor Bloom or talking to colleagues in Cardiff. We very often talk to each other for different reasons, and whether they have told me, I don't know, but I've heard about it, yes.
Did Professor Bloom ever suggest to you that the cause of his patient's AIDS was something other than the treatment he'd received with factor concentrates?
No, he didn't discuss that. He didn't discuss that with me. But if you ask me whether he could ever, even if he discussed it, could ever said that with me, I don't think he would. I think he would have said it's the constraint.
We know that in December of 1984, UK HCGO recommended a move to heat-treated products. Do you recall any discussions, whether with Dr. Kershid or Professor Bloom, about the move to heat-treated products?
I think as soon as the UK HCDO suggested that we move to heat product, I think Arthur was sort of instrumental in making sure that all of us would have gone to heat-treated product as soon as they became available. And I think we started with Armour, and then we added Qatar later on.
What steps were taken to ask patients who were on home treatment and who had supplies of unheated concentrates in their home to bring those back in? Were any such steps taken?
Yeah, I've asked that question to the MLS, or the biomedical scientist, who was, and I asked him, what did we do? And he said, I'm certain that we asked patients to bring what they've got and we exchange it with the heat-treated product.
Do you recall any difficulties in obtaining sufficient supplies of heat-treated products?
No.
Do you recall whether any of your patients were infected with HIV through the use of heat-treated products?
Yes.
What can you tell us about that, again, without identifying any patients?
Well, it was a patient who was on Armour products. And to be honest, we would probably not have known about the cause until I think the Armour product was identified, because that batch, one of the donors was an HIV, later developed HIV and AIDS, and he had donated. And then we had to follow all the patients who received that product, and sure enough, one of them converted on that product.
Could we have on screen HCDO 40 132_039, please? Sir, I understand there's a problem with the external broadcast, and so I'm being asked by RTS if we can have a break so that they can resolve that problem.
Yes, I just had that message myself. So I'm sorry to stop you in mid-flow, Professor. It's happened twice this afternoon, but I hope we'll have better luck a bit later on. We'll take a break now. We normally have a break in the afternoon. We have a break for about half an hour. So we'll do that now and come back at 3:30. Gives us all a chance to have a cup of tea and for our broadcaster to resolve what the problems are.
Thank you.